This is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac version 4.20 upgrade call, January 30th. The call is going to run from 2 o'clock to 2:50 this afternoon Central Time. It's going to be a 50-minute call because we have another call starting right at 3 o'clock. Hopefully most everybody can join. These calls will be recorded if you're not able to join or you need to jump off early, and they'll be posted up on the website in a few days. So just a quick overview of the agenda. On the line with me, I have Donna McDonald, Leanne Jones, Melinda Offer, who is managing who is a consultant for STS and managing the FAQ mailbox, and Paul Meehan, who is our programmer over at IQVIA for the upgrades. The purpose of the calls is to walk through the data collection form, talk about the changes, answer questions you may have about the upgrade process, and see where we're at, make sure we're all comfortable with what's coming starting July 1st. With this version, I just wanted to give a little bit of a background on how upgrades work so you understand the process. And I know there probably are some new folks on the phone that may have never heard how the upgrade works. What happens, we had 2.9 go live in July of 2017. We started immediately getting feedback from data managers and keeping all those notes and all the great comments that we got back. Dorothy Latham, God rest her soul, Dorothy Latham and Dorothy was our previous consultant. Dorothy and I started working in April of 2018, going through and organizing, coming up with what suggested changes and ways to kind of make the flow better for the data collection form. We gathered all that up together, and then starting in October of 2018, we started twice monthly calls, and sometimes 3 times a month calls with surgeons going through the forms and talking about all the FAQs that were coming in, ways to improve. We went through each field meticulously, looking at how the frequencies were captured, what our audit results were looking like, and making changes to make this a much better try to improve it as much as possible so we could improve the flow of data, make the burden for abstractors less, and help clarify in the training manual the best that we could. So in doing all of that, we completed all of that I believe last April or May, and as we were going through the transition with IQVIA during that time, we also started working on reprogramming or getting the data specs ready for this upgrade, working with the surgeons, finalizing any last-minute questions. We did beta testing with a group of data managers on this form. It was presented at AQO. We got feedback from that meeting, and we were able to make some changes. And now we're here today with the finalized form. What happens next is now that the data specs are built, the data specs get sent out to the vendors along with the software specs, which are just about complete. Those all get sent out to the vendors so they can start programming. We then, on the other side of things, Melinda and I will start working on the training manual, and I know Melinda has already done quite a bit of work on that. So the training manual is planned to come out probably mid-May. Early May is probably the earliest, but I'm guessing mid-May, and surgeon worksheets will follow shortly thereafter. The form that's posted online now is just a Word, non-annotated Word document. We have the annotations now from DCRI, so I've sent over to our marketing team to post three PDFs, the changes, the marked changes, the clean form, and the change document with what was removed and what was added in. So there will be 3 PDFs, 2 Word documents will be posted, and then as soon as we get the data specs out to the vendors, we'll post those online too, and then followed shortly thereafter by the software specs and then the training manual in May, along with the surgeon worksheets coming shortly thereafter. So that's how the upgrade process works. And now I'm going to go switch over to these 2 forms here. I hope everybody can see my screen okay. We're going to take questions at the end, so if you can enter your questions into the Q&A box, we'll get to as many of those as possible. I'm going to talk till about probably 22 or maybe 2:35 Central Time, and then we'll take questions go through questions after that time. The two forms we have here, the one on the left side of your screen with the yellow, the blue, and the green, this is a very draft form that we used for AQO. October 1st of 2019 is when this form was pretty much has not been changed since. And then the form on the right is that feedback we received from AQO and a really cleaned up version with the new sequence numbers and short names. And this is the form that is going to be posted online now and sent over to the vendors. So we'll just walk through some of these changes and start here with the administrative section. We just removed the cost link section. There felt no use for that. And as I'm going through these sections, if you want to put your questions in, if you have more questions, put them in the Q&A and I'll get to them as we can. The demographic section, we added the word permanent street address. This field before was just the street address as to where the patient was at the time of surgery. What we're looking for by adding, we had street address and then we asked was it permanent or not. What we really want to know is the permanent street address so we can get more into the geocoding, looking at socioeconomic factors for risk modeling in the future. So those two fields, this field was removed here in yellow that talked about the permanent street address. This race documented, we were able to make these a select all. So instead of having to answer each one of these yes or no, you're just going to select all that apply. There's a parent field here that says race documented, yes, no, or patient declined. You have to answer yes to this to answer, if the patient was white and black, you would answer, check both of these boxes for that section. Scrolling down to the hospitalization. We did a little bit more here. We removed all of these. As we were doing the upgrade, we looked at frequency and we looked at ways that we can condense to help make it easier. Sites who work with vendors always have the option to add additional fields into your software. So if there's something here, if you do have a large military population or you do have a large Indian population, these are things where you could work with your vendors to collect those separately. They could add in those custom fields for you. But for purposes of the general adult cardiac population, all of these 5 choices here were extremely low in frequency. So we're lumping them into other. They do not play into the risk modeling. The 2 factors that play into the risk modeling are commercial health insurance, I believe HMO, and I believe the Medicare, the 4 choices, I believe that play into it. I would just have to verify. But I know Medicare for sure, self-insured, and I believe commercial and health HMOs play into it. So we kept those separate. Those had the largest frequency, and if patient is anything other than that, you would just select other. For the Medicare patients, we tried to clarify this a little bit better, and we'll provide further clarity in the training manual. We have commercially managed Medicare plans. Those plans, commercially managed Medicare plans, and I know there's some confusion if the patient has a supplement or if the patient has an Aetna type of insurance where they have like the I think it's Aetna, or they have it's no longer directly through Medicare, but it's a plan that the patient purchases from the commercial insurance. That insurance company then gets funding from Medicare to offer the plan to that patient. Those are commercially managed Medicare plans. You would select yes to those. The same thing if the patient has Medicare. They want the HIC number or the MBI number. These are the new Medicare numbers that, since they're going away from Social Security numbers. And I think actually this is supposed to be moved over. We'll have to fix that. So as we're getting down here, we go into the risk factors. And let me see if there's any questions on that section first before we keep moving. Okay. On the risk factor section, We added a calculated BMI field. This field is going to be calculated by your vendors, and it's going to be the calculation using the height and weight in centimeters and kilograms. The dyslipidemia field, this was a really hard field to capture, and it's oftentimes not documented correctly. This does not play into the risk modeling of your patients, so we removed it because of the high inaccuracy of this field. So that field is no longer being collected. We then added a few fields down here on illicit drug use. This previously, we had captured this. It was not a defined time frame. What we want to know, what the surgeons really want to know, is if your patient that had surgery had used illicit drug use within 1 year prior to surgery, and if they had, was it intravenous drug use, and if also if they had, was their drug use used within 30 days of procedure. They're really looking at these endocarditis patients and trying to look at these a little bit closer here with these two questions. We removed depression, and the choices here for illicit drug use is yes, no, or unknown. We removed recent or remote because we're just looking at the 1 year time frame. The depression field was removed. Again, this is a really difficult field to objectively capture, and oftentimes it may be provided as a word of mouth from the family. Maybe it's not a true diagnosis. So we've removed this just because of the high inaccuracy rate of that field. We get down here into alcohol use, and we did a little bit of finagling here because we had a hard time with these liver transplants and child Pew scores, so we did a little moving fields around here. Liver disease is a standalone field. Yes or no to liver disease. We're removing, I believe we're going to remove liver cirrhosis from this definition. We're capturing liver cirrhosis separately here, and then if they do have liver cirrhosis, the child Pew class score is specific to liver cirrhosis, so now it's going to be a child of liver cirrhosis. The next field here, we removed these two transplant fields. This thoracic aorta disease, again, we capture this with the aorta. We have this captured in the aorta section and in the previous procedure section. And this chest wall deformity field was a very low frequency, and the surgeons didn't feel that we needed to capture that anymore. Again, if these are fields that your sites are using for anything, you can always use your vendor to add those fields in, but the frequency on these were very low throughout all of the database. Okay. We're scrolling down here. The MELD score now uses the addition of the sodium, so we added sodium here, and we'll update that calculation when we get to MELD score calculation here. We'll update that calculation in the software specs to include the sodium part of the calculation. And then we remove the 6-minute walk test. We're keeping the 5-meter walk test because of the obvious link between frailty and poor outcomes with patients. It would be really great if we could capture a lot more data on this field. Unfortunately, this has been a really difficult field for sites to capture or participate in or have a plan to capture this, but there is a great indicator between frailty and how well your patients are going to do afterwards. We would love to include that in the risk model if we get enough data, but we just haven't yet. And then we get to the previous cardiac intervention section. And I think after this section, I'm going to stop and go through some of the questions that we have, just so I can stay relevant and make sure I get those answered. Previous cardiac intervention section. The only change here is that we removed in this part where it's under previous cardiac intervention, we removed where you have the previous PCI, what type of stent was inserted. Just that was a very difficult field for data managers to capture, and sometimes it's not even dictated, or the dictation maybe is contradicting some other dictation that you have in the chart. So we removed that field. And then other previous cardiac intervention, we just changed these names, ablation from fibrillation to arrhythmia. So these would be ablations for arrhythmias. And we added the term permanent to pacemaker, myectomy for congenital, and we fixed that was had a spelling issue, so we have those now. So I'm going to stop here at pre-cardiac symptoms or preoperative cardiac status and go through the question box and see if I can't answer some of these. Okay. So the first question is, why are there so many trial numbers? Patients can only be in one study at a time. So I think we're going to need, I believe, and Donna, if you're on the line, I'm going to unmute you. If you want to talk on this, I believe that we have had patients that have been in a couple of studies, or we've captured a couple different STS trial numbers on patients. That's why we have more than one option. Did you want to clarify that any?
Yes, and I can't speak to certain ones that were being done at the same time, but I know it's something the surgeons wanted. We can do a little more research on that if you want, but it's rarely used, so I don't think it should be a problem for you.
Great, thank you. Next question, what do we use as a permanent street address when patient has a northern and southern address? So for patients who maybe stay in Michigan and travel down to Florida for the winter time, you would use their permanent street address in Michigan, as that's where they spend most of their time. So we can clarify that in the training manual as where they spend the majority of their time. Next question. How does one know if an address is permanent? That's something you would just have to clarify with the patient and do your best with that field. We'll provide further clarification in the training manual and further instructions in the training manual. All of these questions are great because it makes us know, as Melinda and I start on the training manual process, what needs to be clarified. So I appreciate all these questions. If your patient has HMO Medicare, how do we mark HMO Medicare? So if it's a supplement and they have HMO Medicare as primary and then HMO is a supplement, you would mark that as Medicare primary. You would mark that as Medicare primary and fill in the information for Medicare, and then you would mark the HMO secondary. Where will we find the new Medicare numbers? The new Medicare numbers are on the Medicare cards. And they should be, if you have access, and I hope most of the data abstractors do have access to the patient face sheet, they should be on there for billing purposes. If not, I would work with your supervisor to see that you could get access to that information. I know they have different limitations inside of Epic and other EHRs that they can limit access, so you may want to ask if you could have access to that information. So Part D Medicare is your is like your Blue Cross Advantage plan. That patient has to pay into Part D of Medicare. The question was, where does Part D Medicare go? That's actually, the patient has to pay into Part D Medicare in order to take advantage of the Medicare Advantage plans, of the Blue Cross Blue Shield Advantage plans. So that would be your commercially provided Medicare insurance. Under Medicare secondary insurance, you have the HIC number twice. Let's see. So we have the commercial managed plan, yes, and if yes, we also have this Medicare is also, this should be a child of Medicare, this HIC number, and then if that's yes, then you fill in the HIC number. So it's listed there once. For race, if a patient is unable to determine their race, would we code no for race documented? Yeah, I guess you wouldn't have a race documented on that patient, so you would code no for that patient. I'm going to unmute Melinda here and see if she has any insight into that. Melinda, what do you think on that one?
I'm sorry, can you repeat that, Carol? I was writing down some of these questions for the training manual.
Oh, don't worry about writing them down. We have them. I'll send them to you in a sheet. We have them all captured. The question is for race. If a patient is unable to determine their race, would we code no for race documented?
I would think so.
I agree with that. Yep, I would say no as well. My hospital, the next question, and I got these, Melinda. I'll call on you if I need to call a friend. My hospital does not allow us to enter HIC MBI numbers. Is that going to be a problem going forward? No, that's not a problem. If your hospital doesn't allow you to enter those numbers, then they are not required for file submission. Will anything need to be done on the IT side? If you're referring for the upgrade process, how it works is the vendors update their software, and then they will push out this new version to you, to your site, and they'll probably have to work with your IT team, but that will be between your hospital and your vendor. Couldn't we have weight and height fields that we enter in pounds and inches and then calculate in kilograms and centimeters? Too many hospitals still are not on metric scale, and this just adds the abstractor burden and is one more place that a mistake can be made. So actually medications are calculated in kilograms and centimeters. They use body surface index, I believe, to calculate different medications. So these kilograms and centimeters should be available to you, and if they're not, we can provide a link in the resource document to a calculator that can help you with this. We can provide that link in the beginning of the training manual. I think that's a great idea to do. Is STS capturing vaping? To clarify, illicit drug use, opiates, cocaine, heroin are included, but a patient with opiate abuse put on a prescribed drug plan would not be marked as yes. So actually we have a field because CMS is starting has started a new measure that wants to track prescription drug abuse, and that field is going to be down at the end, and we'll get to that further when we get to the discharge information and postoperative information. So illicit drug use, we are not capturing vaping in the where was it at? In the tobacco use section, we're not capturing vaping alone. We are capturing nicotine use in that section, and we'll clarify it in the training manual. And then the opiate drug use is being captured towards the discharge section, and we'll go over that in a future part of this webinar or another webinar. Does having Medicare Part B mean that the patient has fee-for-service? How can we tell if Medicare Part B is primary or secondary? So if the patient has Medicare and Medicare Part B fee-for-service, Medicare Part B is fee-for-service, so you would mark that. And then how do you tell if Medicare Part B is primary or secondary? Usually it would be it should be listed on the patient's admission sheet which one is primary or secondary. It's unusual for a Medicare-aged patient to have Medicare as secondary unless they're still working. STS version 4.20 is ready by 6/1/2020. When will it be ready for third-party vendor? What the surgery date of patient should include in the STS version 4.20? So version 4.20 will be ready for sites to abstract into on July 1st, 2020 with OR dates of July 1st, 2020. And it's being sent out to the third-party vendors hopefully this week as soon as we get the data specs finalized. Paul Meehan, I'm going to call on you and just, if you want to clarify on that any, I'm going to unmute you.
Nope, that's it. That's, yeah, July 1st is the mandatory start date. We are getting it sent out to the vendors hopefully tomorrow, and they'll get started on it and get it rolled out to you guys before the July 1 start date. So same as what was done before. They'll be able to update your software, and you'll still be entering data in 2.9 until July 1st. When you say you have a procedure done July 1st forward, it'll automatically start putting it into the 4.20.1 version.
Great, thank you.
Yeah.
Next question, will there be a, thank you. Will there be a list of which data points affect the risk score? So on the website now, there is a list of the risk score variables, and I'm happy to show you all where that's at on the STS page here. If you go to Registries and Research and then National Database, Adult Cardiac, access data collection resources. We're under, this is going to be version 2.9. The risk variables for version 4.20 are not changing because the risk model was just updated from 2008 model to the 2018 model, and those risk variables will stay the same for 4.20. And we'll repost this underneath the 4.20 link. Under 2.9, if you scroll down here to the risk model variable chart, this is where you'll find what risk factors go into what the endpoints for the models. Okay. And then on these forms as well, these double asterisk marks notate what factors, what variable is used in the risk model calculation. And there was a question about any documentation for vertebral disease, and I'm not sure what that refers to. And I believe that we are going to capture that if you're talking about for CVD, we do capture that. Melinda, did you want to fill in on that one at all?
Yeah, we currently capture that now in version 2.9 for vertebral vascular disease under CVD.
Oh, that's what I thought. Thank you. And that's in the training manual. So what do we use as a permanent home address for a homeless patient? You would leave that blank. Can BNP change to include pro-BNP? So we used to collect, and I think it was 2.81, we did collect both pro-BNP and BNP, and we had low frequency on pro-BNP, and I heard it's an expensive test, and we wanted to stick with BNP because that's what we have been collecting. So we are sticking with BNP for this version as well. Race documented needs to stay there as a yes, no. Sometimes it is not documented. So there is a field here that says race documented, yes, no, or patient declined to disclose. So it is on the form. Should Medicare Advantage be listed as Medicare Primary with HMO Secondary or something else? So Medicare Primary is this commercially managed Medicare plan. That's where you would capture those Medicare Advantage plans. How many fields are in version 4.2 and how many were in version 2.9? So I looked at the abstraction fields, the fields that are abstracted by data managers, and this excludes the fields that are listed as temporary fields, the fields that are used in risk model calculation, and we decreased by about just over 30%. Next question, how many data abstractors talk to patients? I have no idea, and that's a great question. Michelle, could you please clarify what you're looking for there? Thank you. So if a patient has Medicare Advantage plan of any kind that gets coded under commercially managed Medicare plan, just want to be sure. Yes, that's correct. We have a lot of patients who only provide a P.O. box and no physical address is available. Can a P.O. box be acceptable since the city and zip code are available? I think you can still answer the city and zip code. Let me make sure here. You could still fill in the city and zip code, and I think we do not collect the P.O. boxes, but the city and zip code is acceptable. Melinda, is that correct on the P.O. boxes?
This is Donna. I thought we told them to add the P.O. box information in the address field since it's free check.
That's my understanding.
Okay. Then we would add the P.O. box into the address field and keep the city and zip code there. Thanks, Donna. Thanks, Melinda.
Oh, sure.
In the mortality section, can we create concrete wording? Okay, so we'll get to the mortality section, and we'll take those questions when we get down to that part. Medicare Part B, is that for patients that only have Part B, or you mark yes if they have A and B? So they can't have B if they don't have A. So you have to mark Part B if they have A and B. Okay, and there's a question here regarding the IQVIA information and the transition to IQVIA. We have a call here at 3 o'clock Central Time. That's a user group call for the IQVIA platform and for the database transition. Please hold your questions until that call, and if you're not able to join, please send your questions into the IQVIA STS support link. I believe race has to be captured per TJC, or the Joint Commission. If we document it as no, then it'll be equivalent to asking about it, which is not the case if the patient wasn't able to determine his or her race. So I think that's a good point. You don't have the race documented, though. So it could be either no or patient declined to disclose. They're both going to equal the same. For purposes of this database, they're both going to equal the same conclusion, and you won't be able to get down to the race fields. If a patient has a Medicare HMO insurance, the Medicare is the primary insurance and the HMO is the secondary insurance. That's correct. So Medicare is primary. They would have to have a Medicare and then like a Blue Cross Blue Shield HMO type of insurance, and you would code Medicare as primary and the HMO as secondary. Race documented yes, no field is not available in the 4.0 version. So it's here, race documented, yes, no, patient declined to disclose. It may have been added after, maybe after the one that you had from AQO, the sheet that you had from AQO, but it's been added here. Where can we go on the STS website to find previous webinars, including this one currently and the one at 3? I can't listen to the one at 3. Okay. So the webinars are located here. I'll get back to the home page. Under Registries and Research National Database. And then if you scroll down just a little bit on this page, this is the National Database homepage. If you scroll down just a little bit, you'll see the STS National Database webinar page. You can click this link here, or you can click on the box, and it will take you, these are the upcoming webinars. Here's the printable schedule for the Adult Cardiac Database for January through March, and past webinars are located here. So you can find all the ones here. The webinars from today and for today probably will be posted earlier next week. And if you have, it says here, and I know you can't join the call, so if you have 2 people that have not received their usernames and passwords, you can reach out. Let me see if I have my, you can reach out to me, and I apologize, I didn't have this on here. One second. And my email address is down here on the bottom of the screen. So please reach out and I can forward that information over to where it needs to go to check on the status of those updates. Is the HIC is the same as the member ID number? So the HIC is the kind of the new number that's coming out from Medicare. It's not on all of the cards yet. I believe it's taking place of where the Social Security number was at. So we haven't got, there's a question here that's further down and we haven't gotten there yet, and I'm taking questions on the sections that we've reviewed today. So any questions that are coming in for sections that we haven't reviewed today, we'll have to hold them, or please join the future webinars and we'll get to those at that time. Will vendor specifications also be available to sites when released to the vendors? Yes, we'll release them to the vendors and then we'll post them up on the site. If we release them tomorrow, I'll try to get them up tomorrow afternoon or on Monday. Well, this is a question about the deadline, and I think we're still having internal discussions with IQVIA and DCRI. Donna, did you want to take that one at all regarding the February submission?
Correct. Trust me, we're lobbying for you guys. We just have to make sure it'll work in reference to other deadlines.
Great, thank you. Next question, why did the version upgrade get named 4.20? How do we jump from 2.9 to 4.20? What happened to 3? So as we transitioned to IQVIA, we realized that we didn't really have a naming convention, or I guess naming convention for how we identified what versions belonged to what databases and the years versions went out and things like that. So what we've done now is transitioning to IQVIA, and as we go through each of the upgrades for the 3 databases, we are naming, we're going to number them according to database and the year that they came out. So Version 4s will remain adult cardiac. Version 5s will be general thoracic. And as the upgrades go out, version 6 will be congenital. And the .20 reflects the year that that version change was made. Will we be able to directly enter into the site starting July? So this is a question for IQVIA, but yes, with this version upgrade, we should be able to, we should have direct data entry available at that time. Will there be a change to the risk model and calculations? The risk model is staying the same. They update the coefficients. They tweak the coefficients a little bit each harvest just to make sure that we're calibrated correctly, but there's not going to be a major change to the risk models. Will high sensitivity troponin be collected? So we haven't gotten down to that section yet, but we will not be collecting high sensitivity troponin. My facility does not allow us to include address information. Is that a problem? No, that's not a problem. If your facility does not allow you to provide us with address information, that's okay. Please provide the IQVIA call information for today. Okay. So that's going to be this one here. It's the second one here, the IQVIA transition. And here's the number and the web ID. I know you all can't click on that, but I'll show you where to find it. So just, again, STS National Database, and then you scroll down just a little bit to view the webinars, and it's listed right here. And you can just click on Join the Webinar when you get there. We're going to be starting that call at 3. What if they sign their Medicare over to HMO? So that would be a Medicare Advantage plan. How do I get login info for a IQVIA call? I don't have it, so it's on the web page there. So Kevin, I have a question here. How would we capture point of service insurance as commercial or HMO? Melinda, do you have an answer to that one?
No, I'm trying to look it up to see what it is. I don't think I've ever quite heard of that.
I knew you were on it. Okay. If you find the answer, let me know.
Okay.
Otherwise, maybe we could provide some clarity in the training manual on that one.
Thank you.
Okay. Okay, here's some clarity from somebody who's emailing in. Race can be documented as unspecified when patient is unable to determine, so it shouldn't be no. Okay, well, thank you. So we'll go ahead with that, and we'll provide that information in the training manual as we get there. Thanks for the clarity. Okay. Is it important to know which insurance is primary and which is secondary? I think it's important to collect that. I'm not sure how it plays into the risk modeling, but I think it's important to collect that and to know which one is primary and secondary.
I think this is Donna, especially if a patient is dual eligible, so if they have Medicaid and Medicare, I don't think it matters which goes in which space, but it's important to collect both of those because it's a risk factor that applies to sociodemographic issues and possibly readmission. So we are hopeful to collect that information for those patients.
Thank you, Donna. How is a commercial HMO plan captured, commercial or HMO? So if it's Blue Cross Blue Shield HMO, you would capture that as a HMO insurance. If I didn't answer your question, please feel free to provide more clarity in the Q&A, and I'll get to it. If a patient has a Medicare Advantage plan, you want us to abstract primary insurance, Medicare, yes, Part B, no, and then secondary insurance, commercial or HMO, correct? No, that's not correct. So if you have a Medicare Advantage plan, let's say it's Blue Cross Blue Shield HMO, you capture Medicare, yes, commercially managed, yes, commercially managed plan, yes. Will we still have the option to not submit Social Security number and address info? Yes, that's correct. You'll still have the option not to submit the Social Security number and address info. There was an issue on the, and we'll talk more about it on the IQVIA call at 3 or at 3 Central if you're able to join, but we are that fix is that was an error that we identified in the platform for IQVIA requiring the Social Security number, and that is to be fixed in an upcoming patch. You do not have to supply that information. Is the 3 p.m. webinar the IQVIA transition or the user group call? It's the user group call, but IQVIA is going to be on the phone because of the transition going live this week. We thought it would be best if they were available to answer questions on the platform and kind of clarify any questions or issues that you all are seeing, so they can hear what's going on your end. So there's a question here, how is bundled services captured under insurance? And I'm not sure exactly what that means, but if you're, and please feel free to correct me or provide further clarity, but I believe what you're asking is how are 2 insurance types captured, or if they have a Medicare HMO type plan. You would capture those, Medicare would be captured here, and then you could capture the HMO if it's two separate plans. It's a Medicare plan and then it's an HMO plan. You would capture Medicare here and you would capture HMO as the secondary, if that's the secondary insurance. Is there a list of all required fields to meet the registry's national report? So under your contract, you're expected to capture all of the fields that you're able to abstract on these forms that are available in your dictation. Are PPOs the same as HMOs? No, PPOs are not the same as HMOs. They're 2 different types of insurance. The insurance Medicare is very confusing. So we can do a further webinar on that when we get through this upgrade and talk more about just the insurance in the Medicare section, and maybe we can get some experts on the line with us to go over that a little bit better too. The IQVIA call you referred to on the screen is the 2-5 call. So I apologize if I was confusing on there. This is this user group call today at 3 o'clock is a user group call, but IQVIA will be on the line to answer questions. The next call on February 5th is related just to the IQVIA transition, where we'll have IQVIA showing demonstrations and walking through different scenarios that you may be seeing. The user group call is it's your call to ask questions as you're going through this process. To get your questions right now with them on the phone so we can clear up things as quickly as possible. The transition call is just is more of a demonstration type call with more of a didactic portion and then a short questions and answer section. I apologize if that was confusing. Okay. If patient has Medicare A, Medicare B, and commercial insurance, do we count A as primary and B as secondary and do not count the commercial insurance as all? No. So if the patient has Medicare B, you capture that as Medicare. Medicare B is just kind of like a higher up level of Medicare. So you have A and then you have B, which covers a little bit more, and then you have C, which covers prescription drugs, and then you have D, which is actually Medicare Advantage plans. So you would capture Medicare as Medicare. Any Medicare is Medicare. If they have a commercial insurance as a secondary insurance, you would capture Medicare as primary, and then you would capture the commercial insurance as secondary. If we are all having trouble with the insurance portion, how accurate is it going to be? So I don't know that everybody has trouble with it, but I think we're going to focus this on the webinars to go maybe talk a little bit more about it, and we can also do a section maybe we can talk about doing a section at AQO and really dive into it with some questions that you all are sending in and try to provide that information to everybody. I think we just need to really educate folks on it. And if people are good at insurance and they understand it better, then I think those would be our leaders for these types of questions. But we can also just do a straight webinar just about insurance to get through all this. Can we stay on the same login for the next webinar? No, it's the different login. So it'll be, I'm going to move this one off the screen. So it's going to be this user group call, January 30th at 3 p.m. Okay, so it looks like we have about 3 minutes left here before we need to go. And we got through this section. I think if there's no more questions right now, I think I'm going to end it here just so we can all take a quick break and hop on the next call. And I appreciate everybody joining. Oh, if you have any questions or you need to reach out to me, here's my email address. It's ccrone@sts.org. I'm happy to help you and get through this transition and get through the upgrade. Okay, one more question came in. Why do you not include both BNP and pro-BNP in the risk model? Because we do not have enough data for pro-BNPs to include them in the risk model to figure them in the risk calculation. So we didn't have enough of that data to use in the development of the risk models. If your hospital only does pro-BNP, then you do not need to fill in the BNP field. Again, you could have if it's something that you wanted to track at your hospital, it's something your vendor software, your vendors can add into your vendor software. But if you do not have BNP, then just leave that field blank. Okay. All right. Well, that was a great call, everybody. Thank you for joining, and we'll talk again soon. Thanks, Donna. Thanks, Melinda. Thanks, Paul.
Thanks, guys. Bye.
Bye, everybody.
Bye.